Hello and welcome to another live broadcast with MedStar Health. My name is Michelle Carter, and today I'm joined by our orthopedic surgeon, Dr. Suraj Bolarinwa, discussing hip and knee replacement. While hip and knee disorders are common, such as osteoarthritis, they can also be complicated to treat, especially in cases where surgery is necessary. So that's why it's important to see an orthopedic surgeon who is experienced in hip and knee replacement. So we have lots to talk about, so stick around to learn more. Share this broadcast with your friends and ask us your questions in the comments below. We're going to take some time to answer those as well. So as we get started, Dr. Bolarinwa, thank you again for joining us today. Could you tell us a little bit about yourself and the work you do at MedStar Health?
Thank you. So I'm an adult reconstruction specialist at MedStar, which means I mainly focus on hip and knee replacements. I work at the MedStar Montgomery Medical Center at Olney, Maryland. I also see patients at the MedStar Urgent Care Center at Gaithersburg. I see patients from ages 30 to 85 years old, depending on the pathology. So, yeah.
All right, well, thanks again. Sounds like you treat a wide range of clientele, so that's good to know. I'm glad I think our audience is glad to know about that and wants to learn more. So let's dive into some of our questions. All right, so is surgery the best option for treating osteoarthritis? Are there any other options?
Yes, there are a variety of other options to managing osteoarthritis. Surgery should be the very last options. The first line of option is non-operative treatment measures. The most important of all is weight management, if appropriate to the patient. The next set of non-operative managements include, physiotherapy to strengthen the muscles around the arthritic hip joint. Then we have medications we can use like anti-inflammatory medications if appropriate to the patient. For some patients, we will do a steroid injection into the joint to help decrease the inflammation in the particular joint. And for some patients, we use brace to help stabilize and offload the joint in question. So while surgery is the best option, is the cure, it should be the last option after you failed of all these non-operative treatment measures. And it's most important to say that we do not take, or I personally do not take surgery lightly. Before you think about having surgery for arthritis, you should discuss this with your family. You should make sure that you see a qualified orthopedic surgeon and you are appropriate to proceed with surgery.
Thank you. That's good to know, that you encourage patients to be proactive about their health. That way we can, at least do our best to avoid surgery when possible. It's a major, undertaking. So I'm glad to know that our team doesn't take it lightly. So that's good to know. Thank you very much. And speaking of surgery, how long do hip and knee implants last?
That's a question I get very often, and the answer to this question has changed more recently as we've gotten better technology and we've gotten better in making orthopedic implants. The longevity of these implants have gotten better over the years. As of the last, literature I reviewed, most hip and knee replacement implants last about 20 years. An easier way to explain this to my patient is that if you have your hip or knee replacement today, you have a 90 to 95% chance that your hip and knee replacement implant will be functioning in 10 years. And if you take that to 20 years, you have about an 80% chance to 85% chance that your hip and knee replacement will be functioning in 20 years. So for every year you have your hip and knee replacement in place, you have a 0.5 to 1% chance of failure.
Thank you for clarifying that. Those are very important details to know. if you do go that route, will a patient need general anesthesia?
Um, General anesthesia is safe and is still used, but generally across the board now, we use regional anesthesia. What I mean by that is that we do a spinal anesthesia in which medication is placed into the patient's back to give them pain relief so they don't feel pain during surgery. And in the case of knee replacement, in addition to the spinal anesthesia, we do what is called adductor canal block, in which we place local anesthesia around the knee also. And then this will be complemented by sedation, so the patient is asleep through the surgery. For some patients, which we cannot perform regional anesthesia, then we'll do general anesthesia. But typically, we try to avoid general anesthesia as it causes some side effects like nausea, drop in blood pressure, and things like that.
All right. And sort of going along those lines in terms of the next steps and what patients can expect in terms of returning to their regular daily activities and regular life. Could you share when a patient, typically, I guess, I think it, might range from patient to patient, but typically in terms of what you've seen, when can a patient expect to drive, return to work, shower? How long is that recovery process?
Thank you. I get this question quite often. So I'll take this one at a time. Regarding shower, most of my patients can shower next day after surgery. And you can do this because the dressing we place over your incision is a water resistant or waterproof dressing, so you can shower. But we'd advise you not to soak your body in a bathtub. Regarding driving, the average time it takes a patient to go back to driving is between 4 to 6 weeks. And I tell most of my patients, before you return to driving, make sure you have a family member take you out to an open parking lot or a back road to test your braking speed to make sure that you can brake as needed. And lastly, when it comes to return to work, with knee replacements and hip replacements, I tell my patients, if you have a sedentary job, I mean like a desk job where you just sit by your computer, most of those patients can go back to work in 6 weeks. I would say 4 to 6 weeks. If you have job where you require to do lifting, you go up and down steps, those patients, I would tell them they should expect to return to work in about 3 months. So it's patient specific, and it depends on the type of job the patient does.
All right, that's good to know. And important things to consider too when it comes to returning to your daily activities. So could you also share, can you have hip or knee replacement and go home the same day? Is that an option?
Yes, actually, that is starting to become the norm now. About 40 to 50% of my patients go home the same day. Now, going home the same day is not for every patient. This is something where, I look at some certain criteria to make sure that the patient can go home to the same day. The most important thing we look at is your health. What other medical issues do you have? Are you healthy enough to be able to go home the same day? Secondly, is what barriers do you have to going home the same day? Like, how many steps do you have at home? Thirdly, do you have enough of support at home? Do you have help at home? Do you have a spouse at home that's willing to help? And the most important factor in if you can go home the same day actually is how you're doing post-operatively. How is your pain? How is your strength? So we have our physical therapist who would evaluate you after surgery. They put you through a barrier of tests. You go up steps to make sure you can safely discharge home. So a lot of our patients do go home on the day of surgery now.
That's good to know. Thank you very much for sharing more about the process. So we talked about hip or knee replacement. So is it ever, or when is it ever appropriate to have a partial knee replacement?
Yes, we do partial knee replacement quite often, and we only do it for patients that have arthritis localized into one joint in the knee. So there's three compartments in the knee. There's what we call the medial compartment of the knee, which is the compartment that we see most of the arthritis at. There's the lateral compartment of the knee, and also there's the patellofemoral compartment of the knee. So with partial knee replacement, you can have a medial compartment arthritis where the arthritis is only located in the medial compartment of the knee. So for this patient, before we consider partial knee replacement, I have to be able to demonstrate and replicate that the patient's arthritis is localized to that compartment. So we can go and only replace that compartment. And the way we do this is first we get x-rays and we make sure that the other compartments of the knee do not have arthritis. Also, I get a good detailed history from the patient to make sure that their pain is only localized to that compartment that I'm seeing the arthritis. And most importantly, I get the patient's past medical history. Partial knee replacements is contraindicated in patients that have rheumatoid arthritis and patients that have severe deformity of the knee. So partial knee replacement is not for everybody. And we have to make sure that we pick the right patients for this.
All right, that's good to know. So we talked about hip and knee replacement. We just talked about partial knee replacement. Are there any minimally invasive options for hip and knee replacements?
Yeah, so the word minimally invasive, it's something that my patients typically ask me about. What is minimally invasive? And I think that typically involves the length of the incision when we want to make the length of the incision as minimal as possible. But most importantly, we want to make sure that the soft tissue dissection underneath the incision, we cause less trauma or disruption to this soft tissue. So for knee replacements, we make the incision small enough for us to be able to do the knee replacement safely. But most importantly, we try not to violate the soft tissue as much. For hip replacements, I do most of my hip replacement through anterior approach. This is considered minimally invasive because you do not violate a lot of the hip stabilizer and the hip musculatures. You go in between the planes of the hip muscle. So this allows quicker recovery and less soft tissue damage and swelling to the patients.
All right. I have one other question before we delve into some audience questions. We've started receiving some of those. So could you share a little bit about the success rate and share how successful hip and knee replacements are?
So I'll separate that question. Hip replacement is very, very successful surgery. About 95% of the patients that get a hip replacement are satisfied 10, 15 years down the line. Knee replacement is also very successful, and about 80% of the patients who have a knee replacement are satisfied after having a knee replacement. So both of these surgeries are very, very successful surgeries, but most importantly, they make lasting impact in patients' quality of life.
I think that's very important. Everyone wants to maintain a good quality of life. And that takes me into our audience questions. If you're just joining us now, thank you for tuning in. I'm here today with our orthopedic surgeon, Dr. Suraj Bolarinwa, discussing hip and knee replacement. While hip and knee disorders are common, such as osteoarthritis, they can also be complicated to treat, especially in cases where surgery is necessary. So that's why it's important to see an orthopedic surgeon experienced in hip and knee replacement. We have more to discuss, so stick around to learn more. Share this broadcast with your friends and share your questions with us in the comment section below. So right now, I want to take some time to answer those audience questions. We have one from Snooky. Thank you, Snooky, for tuning in. They say, when you have had knee replacement, how frequently do you have to have that same knee replaced for a second time? Is there some type of waiting period? that the patient needs to consider?
Before having the same knee replaced again?
Yeah, if they feel the need that knee needs to be repaired or looked into.
So, like I mentioned earlier, most knee and hip replacement will last for about 20 years. We're expecting with new technology that the hip and knee replacement should even last longer than that. But based on the recent studies we have, we're estimating 20 years. So there's a variety of reasons why you might need to have what we call a revision, which is a redo of your hip or knee replacement. The most common reason for that in America nowadays is infection. If you have infection in your knee, infection can present in multitude of ways. One of the ways it presents is pain and swelling in the knee years later. And we do a variety of tests to make sure that the knee or the hip is not infected. And if it's infected, then we go in, we take out the hip and knee replacement, we put an antibiotic spacer, and then we let that get rid of infection. Then we later go back in to do the redo. All the reasons why you might need a redo could be if there is failure of the implant, say the implant did not bond to bone or is loosening and is causing the patient pain and is affecting the patient's quality of life, then we can go back in and redo the prior surgery that was done. So those are the two common reasons why we go do a redo of a hip or knee replacement. The last one I will mention also, it's where you have wear in the plastic, which we call the spacer, that is in the knee or hip replacement. If that plastic wears out and it starts to cause inflammation and pain in the joint, then we can go back in and just replace that plastic.
Okay, so it's not as if you have to, reinvent the wheel and just go in completely as if it were the first
Yeah.
time.
Yeah,
Okay.
if you have a knee replacement that is well functioning and you have no pain, you're able to walk around, you just need to follow up with your orthopedic surgeon, maybe once every few years, 3 to 5 years, and to get x-rays to make sure the implant is well positioned and everything is going well. If you don't have pain, there's no need to go back in to redo it.
Okay, got it. Thank you very much. And thank you, Snooki, for sharing your question. We hope you're doing well. I have another one from Robin. So we sort of delved into this a little bit earlier, but they're asking, can you discuss the alternatives to full knee replacement?
Alternatives. I'm not sure I fully understand what alternatives would be. Having non-operative measures, like using brace, using steroid injections, using vicious supplementation injection, doing physiotherapy, losing weight, and not having a full knee replacement. Alternative could be the partial knee replacement, which we talked about, if the arthritis is only localized to one compartment of the knee. So I'm not sure if I'm answering the question correctly. I'm not sure I fully understand what the person is trying to get at.
Okay. All right. I hope that answered your question, Robin. If not, feel free to share another comment below, and we'll take some time to address that. But thank you for sharing your question. I think you answered it well. We have another question from Tony, who's asking, what's the maximum weight for total knee replacement?
That is a good question. We don't go off weight, we go off your body mass index, and this is, so most surgeons have a BMI cutoff of 40, which means your body mass index of 40, which looks at your weight in combination to your height, okay? There've been lots and lots of literature and research that has shown us that doing hip or knee replacement in patients with BMI over 40 puts them at risk of complications post-operatively, infection, wound healing, pain. So we try not to do hip or knee replacements in patients that have a BMI greater than 40. So you can talk to your primary care doctor, get your BMI, and see if you're over 40 or not. And this is one of the all the reasons why I keep mentioning weight loss. Before you have a knee or hip replacement, you want to make sure that you are at an healthy weight. And because if you do surgery on a very heavy patient, you stress the implant and it can lead to early loosening of the implant.
All right, thank you very much. I think that we also received another slightly related audience question from Deb. I just want to let you know that I think we addressed that question as well, who asked about weight restrictions for knee replacement. So those are important considerations in terms of your BMI before you make that decision for the knee replacement or hip replacement. All right, we have another question from Karen, who's saying, is there still a standard that you can't have more than two full knee replacements during a lifetime? I've had two replacements and two revisions already, and I'm only 62 years old. You may have covered this already, Karen says, but what do you say? Is there a standard for the number of times someone can have these replacements?
No, there's no standard.
Okay.
Long as you have adequate bone stock. I recently did a patient that was her third or fourth time having a redo. But before doing this, I had to make sure I understand why the subsequent surgery failed. And if you don't fully understand that, you could harm the patient by doing a surgery where you don't understand why the prior surgeries were failing. In this patient situation, I was the fourth surgery she was having, and I made sure I understand why the prior surgery failed. And I took extensive time to get to know the patient and the patient's family. And I did the redo, and she was in the mid-60s. And so far she's 2 years out, and she's 18 months out, and her knee is doing well. So there's no limit to how many replacements you can have. The limiting factor is the bone quality, your bone stock that you have remaining, because the implant we use, they have to bond or be stabilized by bone. So you have to have adequate bone stock remaining. So that's what limits revision surgeries.
All right, got it. Thank you very much for answering that question, Dr. Bolarinwa. And thanks to all of you for sharing your questions with us. Keep them coming. As we go along, we'll take some time to answer those as well. So at this time, I'll turn over to some of my questions that I have here. So Dr. Bolarinwa, why would a patient, I think you may have answered some of these too when addressing the audience, but could you just reiterate these points? Why would a patient need revision surgery, and how common is it?
Yeah, so revision surgery, the rate of failures of hip and knee replacement in the United States now is about 1%. And the most common reason why you might need a redo or revision of a hip or knee replacement is infection. The second reason is loosening of the implant, and we have wear of the implant also, or you can have fracture around the implant that causes the implant to be loose. So those are the common reasons why we might go back in to redo a knee that was done prior before.
All right. And could you, we already talked about surgery and that entire process, but could you address recovery? What is recovery like for hip and knee replacement surgery?
Yes, so typically after your hip or knee replacement surgery, you go up to a regular orthopedic floor. You start physical therapy the day of surgery. You start walking around with our physical therapist. And then you get discharged either the day of surgery, the next day, or typically 2 days after surgery. And when you go home, that's when you start the real recovery, where you have to start doing physical therapy. For knees, for hips and knees, you can do physical therapy in one of two ways. You can do therapy where you go to a outpatient physical therapy place close to you, where you go a couple of times a week, and you can do physical therapy for knees for up to 3 months until you've gained strength and motion. The goal of therapy is to get you strength and motion so you can go back to your regular day-to-day activities without pain and limitation. For hips, depending on the patient, you might need physical therapy for up to 6 weeks. Some of my hip patients don't need physical therapy. All they need to do is just get up and walk daily, and they gain their normal hip strength back just by doing that. Like I said, it takes an average of about 3 months after knee replacement for you to get back to normal functioning activities without having pain. It could take up to 6 months for you to gain your full strength back in your knee after surgery. Hip is a little bit more shorter. In about 4 to 6 weeks, you can gain, you can be able to go back to most activities. And in about 3 months, you can go back to having full strength around your hip.
All right. So along those lines, talking about the post-surgery period, are there any lifestyle changes that are necessary for the patient to make after they've had surgery?
This is thank you for that question. I get that question a lot. For the average patient, we typically, advise them to avoid high impact activities like running, playing basketball, going skiing. And we also advise patients to maintain a healthy weight. We say all of these things so they can reduce the stress on the hip and knee replacement implant. Of recent, we've been telling our patients, if they want to run, or if they want to jog, if they want to do high impact activities, they can, because the implants are getting better, but it's as they risking wearing out the implant sooner, needing a revision surgery sooner. So you can typically do any activity you want to do, but that it's at a trade-off for needing a revision surgery sooner. And I've had some patients that they want to be able to do everything they want to do, like run every day, go play basketball, knowing that they might need a revision surgery at a later date.
All right. So maybe is it possible for them to just need to scale back those activities instead of, cutting them out altogether? Okay.
That might be another way, is just to scale back, not do it as frequent or not do it as vigorous as, someone with a normal or native anatomy.
Okay. All right. So we talked about the process for hip and knee surgery. We talked about partial knee replacements and even the recovery process. So let's delve into, I guess, some of the technical side of what's available. So could you share what advances have been made in recent years when it comes to hip and knee replacement surgery?
Yeah, with hip replacement surgery, one of the recent advancement, or what is taking steam right now, is anterior approach. And I think I mentioned this earlier, that the most common way to do hip replacement nowadays is posterior approach, but there's also anterior approach. There's no good approach. You just want the approach that your surgeon is more comfortable with. And every approach has its pros and its cons. One advantage to anterior approach is the rapid recovery in the early recovery phase. Because we do not violate the soft tissue, we do not cut any of your muscles, we go in between the planes. It allows for early recovery and, most importantly, less pain in the early postoperative period. But when you look at these patients, either if you have anterior approach or posterior approach, 6 months, a year down the line, it doesn't matter. They perform just as well, but you get an advantage in the earlier phase by rapid recovery. In the knee side, the advancement we've making in that is doing cementless knees. And what this means is that when we do knee replacement, we use a bone cement to glue the implant into the bone. The reason why they develop cementless knees where there's no bone cement in which the implant just bone to your native bone is for patients that are obese, for patients that that do high impact activities like run, because there's no bone cement interface to weaken and loosen up over time. We think that this will allow patient to be able to keep the implant for a very, very, very long time. So those are two new things that's gaining steam now, and I'm very excited about those two things.
Well, that's good to know. Speaking of excitement, I think you may have partially answered this question too, but as a surgeon, what advances are you most excited about?
Well, anterior approach.
Yeah.
It amazes me how well and how quick the patients recover. About 80% of my patients don't take narcotics after direct anterior approach. It's just because they don't have that much pain, they don't have that much swelling. I just typically use Tylenol and anti-inflammatory medication. And I have patients that, they live in townhome, they go home the same day of surgery, they can even go up steps, they go back to driving sooner. So it's something that really excites me, something that I'm very passionate about, just to see that you can make an impact on the patient's life and they can go back to their life with minimal recovery time. So, yeah.
That's amazing. That's amazing. I haven't had hip replacement, but I did have a hip injury shortly before and after I gave birth to my baby. So, yeah, it's no joke. Having a hip injury, you can hardly walk, you can hardly stand.
Yeah.
So yeah, it's not fun. So thanks for sharing about those advances. I'm excited to hear about them too. So as we close, Dr. Bolarinwa, what message do you have for our viewers?
It's again, I'm gonna reinstate this because this is important. Before you consider hip or knee replacement is not for everyone. Before you consider this, you have to have failed a lot of non-operative treatment measures, because there's some people that live with arthritis for the rest of their life and not have surgery. Also, you want to make sure you see a qualified orthopedic surgeon who would evaluate your pain and your needs. So it's important that that hip and knee replacement is not for everyone. We have guidelines, we have BMI cutoffs, and there's a recovery time that is required after the surgery. You just don't do the surgery and go back to your day-to-day lives the next day. So it's important you sit down with your family, you talk to your surgeon, you consider your options, you fail conservative management, and then you start thinking about surgery.
All right. Thank you very much, Dr. Bolarinwa, and thanks to all of you for tuning in. That's all the time we have for today. For those of you who did share questions with us in the comments, we're going to take some time and have those answered by Dr. Bolarinwa offline. So don't worry, keep sharing your questions. We're going to share them with him so he can give you a response soon. So that wraps up for today. If you'd like to learn more or schedule an appointment, please call 301-774-8958. We're going to put that information for you as well in the comments below. All right. Thank you again, Dr. Bolarinwa, for your time. We appreciate it. We'll see you next time.
Bye-bye.
Bye-bye.